All right, I have lots of disclosures. As my good friend Kyle Hogarth says, if you don't see your company's name up here, come talk with me afterwards, and we can figure something out. All right, so let's talk specifically about the Nodify lung nodule risk assessment. And that's the product name, Nodify. That's what you'll kind of get in your head. It's not Nodify, it's Nodify. And we'll talk about how we can better manage lung nodules by using this blood-based biomarker. And this is kind of a setup, right? So you may see where I'm going with this, but I think these are still good examples. So look at the image on the left. This is a patient that has a 2.8 centimeter solid nodule in the upper lobe. Looks kind of ugly. There's a nice tempting bronchus sign right there, just taunting you, saying, come biopsy me. And then there's a small little half-moon shaped lesion that's 9 millimeters on the right side. And so the question is what's your next step for these patients? Are you going to order a biomarker test? Are you going to do a PET scan? Are you going to go straight to a bronchoscopy? And what's the best management? And so now we can kind of flash forward and say, okay, well, what happened with these? Well, the lesion on the left was clearly just inflammatory or infectious, and it's resolved completely about 2 months later. And that 9 millimeter half moon thing that we weren't terribly concerned about 2 years later ends up being a stage 1 adenocarcinoma. So is there a way that we could have assessed their risk more appropriately with a blood test or other methods to determine who we really need to do a procedure on and who we don't? So certainly that first case, we could have done a bronchoscopy and we could have determined that it was an infection, maybe Pseudomonas or something like that, and that would have been fairly easy to do. But I think that what we don't think about is what the patients go through and the anxiety and the cost of their insurance and things like that. So yes, it's easy for us to say, but imagine what the surgeons say. So none of us are surgeons, or most of us aren't surgeons. We hate it when they go in and they just do surgery and cut out benign nodules. For the surgery, that's like doing bronchoscopy. It's easy. I can do it in my sleep, no problem. But there's still a lot of stuff that the patient has to go through. So if we can figure out a way to avoid that, wouldn't that be great? So these are all the things that we know that we have now that we can use, and you should use, because all these things are important, some more than others, as far as trying to figure out whether a nodule is malignant. Smoking history, how big is the nodule, is it upper lobe, is it spiculated, and all those kind of things. And so these are what we're using mostly today, but we know that we're not great at determining what's a cancer and what's benign. I think that I'm pretty good, but I still get thrown off from time to time. So here's the problem that we have, right, is everybody thinks that we have more screen-detected nodules because we're pushing lung cancer screening, but we know that we do a really poor job of doing lung cancer screening. And at the time of this, there was 8 million people eligible. Now that we've expanded the criteria, there's 12 million people eligible. So the nodules are out there to be found, and then not to mention all the incidental nodules that we find. And what we use now is we use these risk calculators. We typically like to use the Mayo calculator or the VA model for incidental nodules, or the Brock calculator for the screen-detected nodules, but they're not always good enough. And so what we end up with a lot of times is we end up in this middle section of this low to moderate risk. Okay, so we're mostly talking about lesions between 8 and 30 millimeters, and we apply all those criteria. And then we're looking at the ACCP guidelines, which are kind of quite out of date, but still that's what we have. And so if they're high risk, based on those calculators, over 65%, then yes, you should send them to a surgeon or do a biopsy or whatever the case may be. And if it's very low risk, a 3 millimeter nodule on the fissure and they've never smoked, then yes, you should feel comfortable sending them to CT surveillance. But the vast majority of these people are in the middle. They're in that 5 to 65% range. So how can we use something to push them out of that and give us more information to make better clinical decisions? Because these are some sobering numbers here. 62% of biopsies are done on nodules that are benign. 35% of surgeries are done on benign nodules. And again, the patient may feel comfortable and relieved that now they don't have cancer, but they also had a procedure and a surgery that they didn't necessarily need. Maybe they're stuck with, neuropathic pain and thoracic pain after their procedure. And unfortunately, we don't always get it right. Currently, 17% of patients that we send to watchful waiting end up having cancer. So we're not as good as we think we are in terms of figuring out what's a cancer and what's not a cancer. So we go back to this diagram and we say, well, wouldn't it be great if we had a blood test where we can push people one way or the other? And so what we've seen is that, we can get 14% from that low to moderate up to high, and we can get close to 50% of these patients out of that big orange bubble down into the very low risk, less than 5%. So that gives us a better shot at making the right diagnosis, okay? And so in that low to moderate risk category, that's when you're going to use this test called Nodify Lung, and it's actually 2 tests in one. It's a rule-in test, which is called the Nodify CDT, and what that does is that detects autoantibodies that are associated with malignancy. And if it gets a hit on that, that immediately pushes them into the high-risk category, and it helps you manage that patient. That test result comes back in 24 hours. So you get very quick answers on that. And if you get a negative test on that, which most people will, then you'll switch to the Nodify XL2 test, okay? And that takes about a week, a little bit shorter than that. And that's a rule-out test, okay? And we'll look at all the positive predictive values and negative predictive values as we go forward. But that's what we're trying to do, is get them out of the middle and push them to one side or the other in terms of their risk. The key thing to keep in mind is that this test is not prescriptive. It doesn't tell you what to do. You still have to use your expertise and your brain. This is an adjunct to your standard care of therapy. So all your experience in knowing what looks like cancer, use all that. You should. This is just meant to help you get more information so that you can see the picture more clearly and make better decisions. So here you can see the respective specificities and sensitivities for both the rule-in test, which is CDT, and the rule-out test. Very well published. You can go look some of these up all the way down to the basic science of it if you want to, as far as digging into what the proteins are and what they do, although we'll mention some of that. The most important thing for me on this is that there's no out-of-pocket expense for patients that have Medicare and Medicaid. When I started doing this test for the Oracle study, which we'll talk about at the end, my biggest concern was, is my patient going to get a bill for this? Even a balance bill, like, okay, your insurance didn't cover $500 of this. And I was concerned about that. Biodesics promised me that nobody would, and nobody did. Several hundred tests sent, and my patients never came to me and said, hey, I got this weird bill, and now how am I going to pay for this? Because if that was it, that would be a non-starter for me. So completely covered, which is fantastic. So these are the criteria that we've validated for this test. So when you have a nodule between 8 and 30 millimeter, your patient was over 40 years old, they have no previous history of cancer, and they fall into that 0 to 65% category. Now, patients are eligible for the Nodify XL2 if they've had non-lung cancer greater than 5 years ago, and if the risk is less than 50%. It seems a little confusing. There's a calculator, there's an app on your phone where you can just put in the criteria and it'll turn green if they qualify to do Nodify, or it'll turn red if they don't qualify. So they make it really easy. And so the other question that we get about this CDT rule-in test is this specific for any specific stage? Is it specific for any different type of cancer? Does it work for small cell, non-small cell? The answer, as you can see there, is yes, it works for small cell and non-small cell across all stages. And some of these, if you look into some of the previous publications, can detect cancer years before it develops, which is pretty interesting. All right, so your results from the CDT test will come back in one of 3 ways, okay? You may have no significant antibody detected level. About 85%, when we look at all the tests that have been ordered, the thousands and thousands of tests that have been ordered, about 85% of these tests will come back that, hey, we don't see any autoantibodies. Why is that? That's because the vast majority of nodules that we find, particularly incidentals, end up being benign. In 10% of your cases, so 1 out of every 10 patients, you're going to have a moderate level of these antibodies, which says, hey, you should take a close look at this. This could be malignant. And in about 5%, so 1 out of 20 patients, you're going to have a high level of these autoantibodies. And that's not quite take it to the bank, but it's pretty darn close, that this patient has a malignancy and that you need to manage their case differently. So this is what a test result looks like, and you've already put in all the criteria when you started. Remember, when you ordered the test, you put in those criteria. It's upper lobe, it's 1.2 centimeters, they're a smoker, and so you get this pre-test risk probability. So on every test that you order, you're going to get that orange kind of graph there to the left, and it'll say, hey, if you just use your calculator, this is what the risk is. And now after the test, on the right, this is what the post Nodify risk of malignancy is. And you see that that jumped from 12% to over 65%. So you push that patient up into that other category, and now you have some answers. All right, so if you don't get a hit on the CDT, then it automatically reflexes to the Nodify XL2. And again, you're still using your same clinical risk factors that you have, and we combine that with this ratio of these two plasma proteins. And so when they started this research, they started looking at 400 different proteins and narrowed it down to 2 proteins, one that's more associated with lung cancer and one that's more associated with inflammation. And they look at the ratio of those two to give you an answer. And so these are the possible results with this test. It will come back as either likely benign, which is about 35% of patients, and that means that they're really pushed to less than 5%. You have 45% of times where you'll say, this is reduced risk. Okay, they're not saying that it's not cancer. We don't put in the words here anywhere, not cancer, don't worry, don't do any more CAT scans. You know, what we do is it's reduced risk. You still have to use the same information. And then in 20% of the cases, we have this indeterminate category. And in my experience, the indeterminate ones actually kind of worried me a little bit, and I've followed them closer because a decent amount of them actually, ended up being that. So that's something to think about. Again, no out-of-pocket expenses with this at all. And this is what the test results look like. So again, you take that same patient where you had your pre-test risk of 12%, you do this test, and it comes back, hey, less than 1% risk of malignancy in this. And so that makes a big difference in how you manage these patients, okay? So this is a distribution looking at 3 different categories. So number 1, the lead-up study to this was called the Panoptic trial, and that was published in Chest, and you can go look that up. And then in the middle, we have commercial tests, thousands of them ordered by over 200 different physicians in the United States. And then we have the data from the Oracle registry, which was just published last month. And so what you're looking at on these violin plots is what is the pretest risk, so that first number, that 12%, for example, and then what was it after the test? And what you see is that so many of these patients get pushed down into that less than 5% risk category, and in some cases up to 47% were reclassified into a lower risk. And so you can really strategize and prioritize which patients need an invasive procedure and which patients maybe don't need an invasive procedure. So this is just a test case that we'll kind of go through. And so this is a 65-year-old female. She's a current smoker, no history of cancer. Her pretest risk is 28%, and we do the Nodify lung test. And so this is a conversation that I have with patients, and this is, we got asked this the other night on the webinars, well, how do you manage this, and what about PET scans and things like that? PET scans are great. I love PET scans. My expression has been cheat as much as possible, and that's what I use in bronchoscopy with throwing in cone beam. That's what I use in this, but I'll cheat as much as possible for my patients. And so anything that's going to get me more information, I'm going to use that to my patient's advantage. So when I talk to the patients, I say, all right, here's the options. We could wait 3 months and do a CAT scan. We could do a PET scan. We could do a bronchoscopy. Or I could do a blood test and call you in a week with more information about which one of those directions we should go. And universally, they perk up immediately when they hear blood test. Certainly some of them think, well, that's the future. This is the way medicine's supposed to be. You're supposed to have a blood test that tells you everything about me. And so they really like that option. So the patient satisfaction that I've experienced with this is pretty off the charts. Keep in mind that PET scans aren't perfect. There's a false negative rate of 15 to 20% with PET scans. There's false positive rates. I live in an area where there's a ton of sarcoid. And so that's not perfect either. So in this case, this patient had a positive CDT test, and they went to over 65%, and so now you know how to more accurately manage that patient. The other option is, again, that the CDT is negative, and so you go back to your 28%, it pushes it to XL2, and then it can swing this far on the same pretest probability. These are real examples of showing you what can happen where you can take the confusing 28%, where they're right in the middle, and push you vastly one direction or the other. So here's a quick case study. This is a 66-year-old female. She has obesity, sleep apnea, she has some respiratory muscle weakness, she's a lifelong non-smoker, spiculated upper lobe lesion, it's hot on PET scan, it's new compared to a year and a half ago, and the PET scan is interpreted by our radiologist, of course, as very suspicious for primary lung cancer. I don't know about your radiologist, mine would say this is consistent with malignancy, and I hate that. So they did a multidisciplinary conference, and they said, well, this is concerning enough. In our brains, this is over 65% risk, so we're going to take this patient to surgery. Well, it ended up being non-necrotizing granulomatous inflammation, and it was histoplasmosis. But then, of course, because of her obesity and sleep apnea and respiratory muscle weakness, she gets stuck in the hospital, gets atelectasis, and has a lot of post-op problems that she didn't necessarily need to have. So again, she could have waited a week, and her physician could have had a lot more information to help manage her case. Again, we're not taking that blood test as prescriptive, like this is exactly what you should do. It's just giving you more information. And so this is an example of what her case could have been and how it could have been managed differently. So lastly, we'll talk to you about the Oracle clinical study that's just been published, and you can see the publication information at the bottom. And so we took this cohort of over 40, 8 to 30 millimeters, less than 50% on the Mayo calculator, and 15 centers in the United States. So this was prospective, observational, multi-center, both academic and community, and we enrolled 814 patients. And so this was kind of a case control thing because we had the registry patients, and then each site went through and they found nodules, and they had to have a detailed chart review. They found nodules of the same size and location, the same patient age and things like that, and we matched them up and said, how are these patients managed without the integrated classifier, which is Nodify, and how are they managed with it? And so that was our control. And then what we did to even more accurately match the patients is something called propensity score matching, where we really filter through and we get down to lower numbers of patients, but they're equally matched, and I'll show you what that looks like. So on the left, our whole cohort, well, we had some differences. There were some differences in prevalence, and then that makes comparing the groups very difficult, differences in age and the nodule types. So then we did propensity score matching, and you see that there's no significant difference between these groups at all. The p-values are not significant. So now we have a better group of patients to compare. And so this is what we ended up with. We have the IC-tested group, that's the Nodify group, that ended up having 16% rate of invasive procedures, and the control group had twice that. So twice as many invasive procedures in the group that were just historically controlled and managed without the integrated classifier. So our primary endpoint analysis was invasive procedures on patients that had benign lung nodules. So we specifically wanted to look at the nodules that were benign and say, how often did we do invasive procedures on these, and can we reduce this? This was our goal with this study. And what we found was an absolute difference of 14% reduction, which is a relative risk reduction of 74% decrease in doing invasive procedures. And so, for example, again, 1 out of 20 patients in the Nodify group had an invasive procedure, again, on a benign nodule. So they did not need to have that. We can also label this unnecessary procedures. 1 out of 20 unnecessary procedures in the IC group, and 1 out of every 5 patients that we had been managing historically before we had the blood test, 1 out of every 5 patients had an unnecessary procedure. Now, statistics can get messy, and some people don't like the concept of relative reduction and relative risk, but the number that cuts through all of that is really this number needed to treat, okay? So we needed to we needed to test 7 patients to avoid one unnecessary invasive procedure on a benign nodule. And those numbers are very important. If you look at other examples of number needed to treat, if you look at huge studies with thousands and thousands of patients, like, studies on Lipitor and statins and things like that, their number needed to treat to prevent one heart attack is about 100, okay? So the number needed to treat, or in this case, number needed to test, is only 7 to prevent one unnecessary invasive procedure. The next question that we got asked a lot, and so we answered this, and there's several abstracts that have been published since then on this, is that it doesn't matter whether the nodule was incidentally found or a screen-detected nodule. It doesn't matter if they're male or female. It doesn't matter if they were a smoker or a non-smoker. It doesn't matter if the lesion was huge or small, as long as it was between 8 and 30 millimeters. It did not matter. The test still performed equally as well in all of those groups. So that's very reassuring. And so then what we found that we're able to do is we're changing the prevalence of malignancy in the patients that we biopsy. So what that means is we're doing a better job selecting who may have cancer and who needs to go have a procedure. So our prevalence for malignancy is 74% in the patients that we did the Nodify test on, compared to typically only 49% before. So we're doing a better job of selecting, and our prevalence of patients that we're taking to the OR to do procedures on is higher. So we're more accurate, and that's a relative increase of 51%. So in conclusion on the Nodify part, again, relative risk reduction of invasive procedures on benign nodules of up to 74%. And you can think about adding this to your clinical practice for 2 different reasons. Number one, you may increase the proportion of invasive procedures that you do on people that do have cancer, and you may decrease the risk of doing unnecessary invasive procedures on patients that have benign nodules. And I don't know about you guys, but I'd rather fill my bronch schedule with nodules that end up, being cancer, and the ones that I could push to watchful waiting, then I can use those empty spots in my bronch schedule now to put more patients that high risk of malignancy in those spaces. So when I do need to go ahead and do a biopsy, and we'll shift into the second part of this talk, and then we'll do some questions and answers. We've been using the ion endoluminal system for about 4.5 years. We did the first cases in the US. I've done about 700 cases. My partner's done over 300 cases. And I'm going to talk to you a little bit about our perspectives and how this system works. And so when we do have those nodules, including the one on the very first slide, that little 9 millimeter half moon thing, if this test shows that that could be a malignancy, we're going after just about everything now. And so this is how I think of things from a director of thoracic oncology standpoint from my program. And what we've seen thus far with most of the platforms up until now, up until recently, is that we're not great at biopsying things that are small. So less than 2 centimeters, you see the diagnostic yield really drop off. And so what we know is that if we can catch this early, we can literally save lives. So these are the 5-year survival rates for patients that have lung cancer. So not all stage 1s are created equal. If this was your family member, think about when you would want them biopsied and what technology you would want them biopsied with. You want them biopsied with a technology that has a good track record for biopsying small lesions, because it literally could save their life, not to be too dramatic. So the ion system is a little bit different, and I'll point out some of the differences compared to the other systems, in that this is a platform that's built on shape sensing. So there's no electromagnetic navigation, which is kind of an older, more inaccurate technology. And if you don't have a way to fix that, then you're left with a lot of inaccuracies. So one of the cool things is this automatic anatomy border. So you see this purple line that's on the pleural surface in the vicinity of this lesion. And that's automatically placed there so that you have that information throughout the procedure. And it places itself on any pleural surface, whether it's the arch of the aorta, the fissure, the diaphragm, the pericardium. So you'll always know where that is, and that's kind of what it looks like in 3 dimensions. And we pair that with this proprietary needle, which is this 3 centimeter long needle. It looks like an EBIS needle, and this actually locks onto the robot, and it comes in 3 different sizes. It's 3 centimeters long and incredibly flexible, so it's really meant to pair with this system that can articulate this catheter 180 degrees. And so then you use that shape sensing information to choose what's the depth on that needle that you're going to set. And so what we've seen is a dramatic reduction in incidence of pneumothoraces, and we'll look at some of the data that backs that up as well. The system design is very different than anything else. Again, this is shape sensing, and it's not electromagnetic, so there's no sensors on you, there's no board underneath you, or anything like that. And so they started off looking at that because that's all there was back in 2013. And they had a larger scope that had a camera on it. So the other systems that are out there have a larger diameter scope to accommodate for this camera that stays on there all the time. The problem is that when you get out there a lot of time, there's mucus, and after you start biopsying, there's blood, and you can't necessarily see where you're going. So what Intuitive did was they said, well, we're going to make a smaller catheter that's only 3.5 millimeters outer diameter, and we're going to have a camera there so you can drive all the way out to the pleura and see that. But then when you get there, you take the vision probe out and you do your biopsies. And then we're going to incorporate shape sensing, which is this laser light shown through this tiny fiber optic channel about the size of a human hair. And that's the basis for the navigation system. So the difference in that catheter size really makes a difference. So if we look at the Monarch studies, what we're seeing is that the average reaches from their own studies 5.5 generations, and that only gets them within 2.3 centimeters of their target. And what we've seen with Ion is that on average you're getting 7 generations, and you're getting within 7 millimeters of your target. And you can see the ranges there, that overall you're getting much closer to the target. And so kind of an extreme example of that really looks like this, where those larger catheters may have more difficulty getting further out into the periphery. So this is what shape sensing looks like on a larger scale. And again, they licensed this technology from a company called Lumi, who was working with NASA. And so it knows where it's at, and not just the tip of the catheter, the entire length and shape of the catheter. And so that knows where that's at all times. And that's, again, the basis for the navigation system. So I feel there's less inaccuracies compared to electromagnetic navigation. So this is what setup looks like. It's a very quick and easy procedure. If you've used other systems, you're going to notice that the setup time takes significantly longer. We do 6 to 8 cases a day, and that's because the setup is so quick. You're literally just connecting 2 magnets, and then you're ready to go. So that's what setup looks like. It's meant to be used in any bronchoscopy suite. You don't have to have cone beam CT scan, despite what everybody tells you. It's meant to be used any bronch suite, regular fluoro, use it with your radial probe, small footprint, and can be used anywhere. So I'll run through a couple case examples for you so you can see cases that we like to do with this. Our interventional radiologists are not typically excited about biopsying lesions that are sitting on top of the aorta, so we do things like this and get a diagnosis. Everything's integrated on one screen, so your fluoro is on one screen, your radial probe's on one screen. You're not looking around the room at multiple monitors. And it ends up being very quick for us. So this is the time that it took us to do registration, navigation, and confirmation, because you can see my radial probe image right there. We use the shape sensing information, so you can see that I'm 9 millimeters from the front edge of this lesion. So I'm 9 millimeters from here. I'm 21 millimeters from the back edge. And if I go 6 more millimeters, I'm into the pleura. And so I have all that information there. Here's another one that might be a difficult place. Can also be a difficult place for tomosynthesis algorithms to see, because you're below the diaphragm, you're next to the spine. That makes things a little bit trickier. So 3 minutes and 20 seconds, and again, these measurements are very helpful to us when we set the needle and do our biopsies. This is one of my favorite cases, because this is really not amenable to a CT-guided needle biopsy. This is not amenable to a wedge resection. And so a lot of places that may not have this technology might have said, well, we're going to wait 3 months and we're going to do a follow-up scan. Hopefully they would do Nodify on it. But if they didn't, they may say, well, let's wait 3 months and see it again. After all, it's 1 centimeter. It's the first time it's ever been seen. This was actually small cell carcinoma. We're seeing so many more stage 1A small cell carcinomas because of lung cancer screening and because we have the ability to biopsy very small things. Instead of kind of telling you to be afraid of your CR and that it might cause interference, we're actually telling you what the optimal fluoro angle is. What's the best angle to put that at to get the best view? All the way up into the apex, not a problem. You can see how far this catheter can really go. And so you can combine this with cone beam CT scan. It's really compatible with everything, and furthermore, it's actually integrated with cone beam CT scan, including the mobile platforms, which is really cool. And that's a level of imaging that's even above tomosynthesis platforms, because you're getting true orthogonal planes in much higher resolution, and these systems are found much more easily. And the mobile systems cost about $80,000 more than your regular C-arms. So most hospitals will go through and update C-arms every couple years. And so you may be in line for an update. So this is one that I did with cone beam. And so here you can see with my augmented fluoroscopy, I'm right on the target in the AP, I'm right on the target in the lateral, and then I put my needle out and right in the middle of this target. And that's how accurate and stable and precise you can be with this platform. Just to share some of my misery that you can all relate to, I showed my pathologist this picture, and he was like, yeah, all I see is blood. So I did another needle pass. I was like, you got to look at this picture. You got to look at this picture. And he's like, I don't care about your picture. All I see is blood. And so I switched to forceps, and on the very first forceps biopsy, we got malignant cells. So we can do bilateral cases, which is always fun. We're doing much more of these. This used to be so taboo that I would probably get booed off the stage for talking about bilateral cases 5-10 years ago. We do it all the time. And so in this case, after 1 minute and 53 seconds, I've got an eccentric view over here on the right, went ahead and did a couple passes, handed off to my pathologist, put my radial probe back in at 7 minutes. Now I've got a concentric view, and now at 17 minutes, I've switched over to the left upper lobe, and so I've biopsied 2 lesions in 17 minutes, no cone beam or tomosynthesis spins or anything like that, and then add 15 minutes for EBA staging, and so in about 30 minutes, we diagnosed this patient with synchronous primaries and cleared their mediastinum. All the way up to the apex like this is not a problem, and you saw this picture before. This is how far out this catheter can get you. And again, you still have a camera out there. You have vision. This is actually what looking at the pleura looks like, believe it or not. And before we had robotics, we had no idea what it looks like out there. We thought that we were just going to be in this big open area of parenchyma, and we wouldn't even know what it looks like. But you'd be surprised how far out the airways are maintained. So let's look a little bit at the evidence. And so when you look at the evidence across the studies, the one thing I want you to look at, the first thing, is what is the average lesion size? Our whole goal, if you remember that first slide, was to biopsy smaller things with improved diagnostic yield. And so what you have to consider is what the average lesion size is. Let's say your batting average is 350. Is it against this guy here on the left in your Sunday softball league? Or is it 350 against this guy? And so if your diagnostic yield is 75%, 80%, is it against lesions like this, or is it against lesions like this? And this is where we really want to push the envelope. And so the very first study done in humans, look at the average lesion size, 12 millimeters, the smallest that was published at the time. And they're going out 7 generations, even out to 9 generations, no pneumothorax, close to that 80% with a prototype system, which isn't bad. More importantly than diagnostic yield is actually sensitivity for malignancy. And so again, robust numbers from the beginning. This is a cadaver study. I'm not a big fan of this, but when we get asked, show me how shape sensing is more accurate than electromagnetic, that's what this study did in a cadaver model. And so they trusted the system, drove out to it, put a needle out, and then did a cone beam spin to see if they were in the lesion. And 80% of the time with ion, completely by itself, the needle was in the lesion. And with an electromagnetic platform, specifically Super D, it was only 45% of the time that it was in the lesion. The chest publication came out. This is the group from Memorial Sloan Kettering, 159 lesions. They're doing bilateral cases too, which is great. 66% of these lesions are beyond the 6th generation. So again, that catheter size does make a difference. And the yield is 82%. Their yield for lesions over 3 centimeters is 100%. And that may not sound like a big deal, but the diagnostic yield for the other robot that was out at the time had a yield of 77% in masses and lesions that are over 3 centimeters. So this was really a step up, and we're having very low incidence of pneumothorax. So we have the PRECISE study, and that will be out very soon. Got really interrupted by COVID. So 6 different sites, academic and community, 11 different users, and we focused on lesions that were between 8 and 30 millimeters. And what we see here, and we've seen this in a lot of data leading up to this, is that we don't care about a bronchus sign anymore. Only 25% bronchus sign in this, and it does not affect your sensitivity for malignancy. So 86 versus 88% sensitivity for malignancy. We're going out 7 generations. All these red dots here, those are lesions that are beyond the 6th generation. And this is with 12 months follow-up CT scan. No cone beam CT scan, no tomosynthesis. This is just the robot. We love those adjunctive technologies. It's great, but if you don't have them, it doesn't matter. You can still do really good things for your patient that you weren't allowed to do before. This is our adjunct. So as soon as we finished that trial, I said, I've got cone beam. I'm going to fire this up. I'm going to see if I can do even better. And so in 230 consecutive patients, we got a yield of 92.2%. And we didn't use cone beam in every case. We use it when and if we feel like we need it. We really like to use it to rule out things. And so if my pathologist says, hey, this kind of looks benign, I want to do a spin and see that I'm right in that spot. And going back to that first slide where we talked about size matters, the yield for lesions 10 millimeters or less is 90%. And that's in more lesions than was in the entire benefit trial that was published in chest. Pneumothorax rate requiring chest tube, incredibly low, 0.5%. How about compared to CT-guided needle biopsy? So this was a study done at the Mayo Clinic, and they compared their robotic data, no cone beam, no tomosynthesis. They compared that with the standard CT-guided needle biopsy. 88% diagnostic yield between both groups. But what did differ is you had 4 times as many pneumothoraces, and in about 40% of patients, they still had to go in and do a staging procedure. Remember, CT-guided needle biopsy is not a staging procedure. And that's with 12-month follow-up. And so the groups out of UCLA and Mass General put out this study using the new 1.1 mini cryoprobe. Again, they don't have cone beam CT scan, very low bronchus sign, and they get a diagnostic yield of 90% just by using a new tool, which is pretty fantastic. And this ends up being great for eccentric lesions. And so they threw everything they had at it, brushes, needles, and forceps. And in 18% of the cases, the only tool that got the diagnosis was that 1.1 mini cryoprobe, and you can see the amount of tissue that they get here. And so again, without adjunct imaging, you can use adjunct tools and still get very high diagnostic yield. And this was a full manuscript using a fixed cone beam CT scan, so really kind of validates the stuff that we had. It's nice to see other centers and multiple users validate the same results that you had. High diagnostic yield, high negative predictive value, very low pneumothorax rate. And the newest publication that just came out last month, this is from a group of thoracic surgeons at Cedar Sinai, 503 nodules. This is really the largest study that we've had, and their yield is 88%. They don't have cone beam CT scan. They're not using tomosynthesis. And look at their diagnostic yield, even for lesions 10 millimeters or less, is over 80%. Very high negative predictive value. So they've been able to use ion. They do a lot of single anesthesia events where they're doing surgery the same day, and they've dramatically dropped their benign resection rate down to 3%. And they're able to get enough tissue for molecular testing in 90% of the cases. So is this generalizable? Well, all ion users have this app on their phone which pulls information from the planning laptop, pulls information from the robot, and then after you're done and you get the final pathology result, you can go in and put in the final pathology result. So we have an idea based on this, and again, this kind of shows the commitment that they're more not just about selling robots, but really improving your program, giving you this information so you can see how your yield trends with time. You can see how long your cases are taking. You can see who's referring you patients. You can see which lobar distribution your lesion's in, what tools you're using most often. But the question is this generalizable? And again, only about 10 to 20% of people who have ion, which is 500 sites and about 900 users, only about 10 to 20% of them have cone beam. So the vast majority of people are not using cone beam CT scan. This is not peer-reviewed data. This isn't from a trial, so don't freak out and say, hey, this is data. This is what the experience of the users is. And so you're seeing robust numbers, so that makes me feel better. I'm sure it makes Intuitive feel better, but it also gives them an idea of, hey, if a site isn't performing well, they can go in and say, hey, what seems to be the issue here? How can we help you get better? So this was our actual learning curve from day one, the very first day in 2019 when we did the first case. And most of our cases end up being under 30 minutes. Sometimes it's over that because we're biopsying 2 lesions or 3 lesions. This is our average daily schedule. Again, we do 6 to 8 cases a day. The ion allows us to have fast turnover. We also have great anesthesia, not afraid to use Sugamidex and reverse our patients and things like that. The other thing that you have to consider is what is the pace of innovation with the company that you're working with. The last thing you want to do is get in with a system and put your actual capital on the line and your political capital to buy a system that's either going to get recalled later, that's happened last week with a navigation system, or that's just not going to innovate and continue to get better. And so what I've been encouraged to see with Intuitive is continued improvement. We now have cone beam CT scan integration with one platform. The next platform is coming, tomosynthesis coming next year. And so a lot of continued improvements rather than selling a robot and just not innovating and not updating things. So it's just continued to get better. And I think that that's something that's important. So here's what the mobile cone beam integration, and there's a setup out there so that you can look. And again, this is not something that's required no matter what other reps tell you that, oh, if you're going to get ion, you have to buy cone beam, which is just kind of a farce because I've showed you a ton of data with excellent results that do not have cone beam. But we know people want to use this, and it's spreading like wildfire. And it's come a long way since I presented the first cone beam case in 2014. It's come a long way. And now this is the mobile cone beam from Siemens. And so you do this spin, and then right at your fingertips, you have this CAT scan, okay? And you see the lesion, you see your tool if you put one out, you see the catheter in great detail. You can see the vasculature. These are things you typically are not going to see with other platforms. And then it's integrated, so not just compatible, but it's integrated. It's there at your fingertips. So it sees exactly where its catheter is. You tell it where the lesion is, and it can update the position for you. There's going to be divergence. There's going to be atelectasis and other things like that. And so what we found in this case in 15 minutes is they registered, navigated, went to the lesion, recognized it wasn't there, did a quick spin, and in 15 minutes they've updated the position, telling you the optimal fluoro angle, and now you can visualize that. So, and I'll end with just kind of showing you what a lot of the data is thus far, and we really want to be in this top left quadrant, okay, where we're less than 2 centimeters and we're above 80%. And again, take this with a grain of salt, different definitions of diagnostic yield. Some people are using cone beam CT, some of these are, I'm cheating, I'm using cone beam CT scan. So what if we took out everything that has tomo, Lumicite, body vision, cone beam CT, mobile, and this is just the platform by itself without any adjunctive imaging. So this is the base, this is your starting point with these technologies. Based on these studies, this is where you're starting, and then adding adjunct imaging onto that is a great idea, but this would be your starting point.